We're going to describe, to give a talk on neonatal nasal obstruction. The objectives of this talk is to talk about preparing of the neonate for imaging, starting with a choice of the exam, selecting the best imaging test, discussion of the common causes of neonatal obstruction and their imaging findings, and discussion of the relevant treatment. For all pediatric imaging, we have this base, do no harm, but for those patients with neonatal obstruction, they are more risky because they are having lowering oxygen level and high CO2, so they are more liable to risk of anesthesia and imaging. So we have to take more measures to avoid harm of these patients and to avoid repetition of the imaging. So first, sedation needs swaddle to achieve warmth of the baby and to avoid motion artifacts. Conscious sedation or anesthesia according to the age of the patient, according to the condition. The associated risks have to be avoided and have to be anticipated, including pulmonary and cardiovascular. Neonatal nasal airway obstruction also needs some measurements before imaging, like nasal suctioning and decongestion, because the removal of the secretions will make the diagnosis more evident in cases of membranous obstruction. Also, orbital shielding is to be made in all patients to avoid the risks of the hazards of the radiation to the lens. Newborn nasal airway obstruction has many causes. The most common congenital anomaly is Choanal Atresia, followed by Aperture stenosis, the second commonest. And the third common is mid-nasal cavity obstruction, which is uncommon and recently started to be reported. The fourth are very rare causes like bucconasal atresia, and others are also rare causes, and they'll be discussed in the images. A patient newborn with cyanosis and respiratory distress while feeding. The constellation of this clinical data must help us to choose the best imaging examination. Which for this baby with cyanosis and respiratory distress while feeding and there is no masses or hypertelorism, the best imaging is non-contrast CT. Here we find this overgrowth of the nasal process of the maxilla. So the diagnosis is Pyriform Aperture stenosis. We have here, this is the process, nasal process of the maxilla, because maxilla has many processes. So the nasal processes are hypertrophied and they are encroaching upon the nasal aperture. So Pyriform Aperture stenosis is causing respiratory difficulty with feeding, caused by overgrown nasomaxillary processes, and are associated with multiple anomalies, especially of the intracranial, like holoprosencephaly, hypopituitarism, hypotulism, and cleft palate. They are more located in the midline of the midface or midline of the brain, and sometimes related to chromosomal deletions. Here is, this is the picture, coronal image, and this is the expected normal cartilaginous appearance of the frontonasal structures of the newborn. Here is the narrow midface anomaly associated with the aperture stenosis, and this is a central single midline incisor tooth. Another appearance of the same age, overgrown of the same case, overgrown nasal process of the maxilla. The aperture is less than 8 millimeter, and sometimes the measurements are not the most important thing. We can measure it subjectively by the appearance of overgrown nasomaxillary process. Also, we have triangular palate because it's hypoplastic, and the central maxillary incisor tooth is usually present in most of the cases. This is a case. Here is the triangular hypoplastic palate. This is the appearance of a prominent ridge we call vomerine or vomerin ridge, and this is the how we take the measurement. It is made across the two sides. So when we are referring to the number 8 millimeter, we are describing the measurement across the two orifices. And this is the image of the patient having this central incisor, and these are the two lateral but the single tooth is the central single center midline incisor tooth. This is the 3D image of the vomerin ridge, and this is the central incisor tooth single and 2 lateral incisor normally, and then we have the triangular hypoplastic palate. In the brain, this is a mild anomaly, which is just partial fusion of the phronesis, but there are no major fusion anomalies of the brain. The choanal atresia, we say that first, it is the most common congenital nasal anomaly causing nasal obstruction, and it is, its incidence is 1 for each 5,000 or 7,000, and it's more in females, unilateral in 60%, and bilateral mostly when associated with syndromes like charge, Aperture, or Crozon, 22q deletion, or FAS. Choanal atresia on the old school, they report that, consider that 90% are bony, caused by bony atretic plate, and 10% membranous. Here we have, we are showing here that there's membranous type, and the bony is formed by the bony encroachment or caused by bony plate. So this is the difference between the two schools. The new school say that the combined is 70% because we consider that the bony is caused by bony encroachment, and the membranous is caused by a membrane here obstructing the posterior nasal passage. And it is pure bony in only 30% of the cases when we find that there is a bony plate obstructing the nasal passage. So the most salient imaging modality, finding is narrow choana, posteromedial maxilla, medially bowed. Here we have this narrowing of the posterior choana, and there is bowing of the posteromedial maxilla. Also, we have thick vomer, more than 3 millimeter. This vomer is very thick for the normal vomer. And you can have funnel-shaped nasal cavity. Here is funnel-shaped instead of the rectangular appearance. And sometimes it may be associated with deviated nasal septum. The measurements are usually made, and there's also average measurements which are not taken deadline. But in the newborn, the measurement of the single cavity of posterior nares is usually 6 millimeter. In a 5-year-old, it's reaching 8 millimeter, and in 15-year-old, it's reaching 1.1 centimeter. In any case of choanal atresia, we have to look on the charge association, especially when the choanal atresia is bilateral. Charge association means that there is, it is an acronym for associations starting with the first number of the first letter of one of all of these anomalies. So it includes coloboma of the orbit, heart defects, choanal atresia, mental retardation, genitourinary, and ear defects. So in the imaging scanning, we are taking for the choanal atresia, we can look at the colobomas and the ear defects. So whenever we look at bilateral or even unilateral choanal atresia, we have to look at the remaining imaging scans for the coloboma and especially the ear defects, which are common. The ear defects are usually can affect any portion of the ear, either middle, inner, or even the nerves of the cochlear or facial or etc. So these are all constellation or variable imaging findings which could be found in charge association. This image showing isolated cochlea, which means, or trapped cochlea, which means that there's absence of the cochlear aperture, which connects the internal auditory canal to the cochlea. So this may be overlooked if we are not intended to look at this anomaly. Also, there is here a very mild modular deficiency, which deficiency of the posterior strut of the modulus, while the anterior strut is very well developed. So this is a minor deficiency which could be overlooked if we're not intended also to look at these anomalies. Here, there's another anomaly here, lack of partition, which can be type 1 or type 2 partition, also can be visualized in case of charge syndrome. This is a case of absence canals, semicircular canals, which is very common also in charge associations. There's an example of oval window atresia, and also the round window can be atretic or hypoplastic in cases of charge. Another anomaly here is a barren course of the labyrinthine segment of the facial canal coursing posterior to the cochlea instead of coursing anterior to the cochlea. Also we say that we may see anomalies of the middle ear, not only of the inner ear. We can see here ankylosis of the medius and incus complex, and both are ankylosed by ankylosed ligaments connecting them to the tympanic wall. Also, we can find there is hypoplasia or even aplasia of most of the nerves. Here, we can find the cochlea at all. There's cochlear aplasia, and the facial nerve is maybe hypoplastic, and the vestibular nerves here, the comma-shaped, is very hypoplastic. Also, we can see the appearance of the retrobulbar colobomatous cyst. So these changes or these anomalies must be taken in our imaging checklist of the head and neck when we encounter a case of choanal atresia. The third cause, following the most common choanal and the second commonest aperture stenosis, is mid-nasal cavity obstruction. When we say mid-cavity nasal obstruction, it means the isolated forms or the congenital forms which are not related to secondary obstructive cause. Meaning that the cavity itself has having narrowing configuration which is intrinsic, not extrinsic or secondary to obstructing cause. Actually, this is called non-choanal, non-pyriform aperture, and the least common after choanal and pyriform, and still the third common because it's more common than the other narrowing bony configurations. Isolated forms are started to be described only in 2004. The first letter to describe it are emerging only in 2004, and the measurements are not yet established, but they are mostly made subjectively. This mid-cavity stenosis can be secondary, like obstruction by maxillary. The other case, the prior slide. Here we have the lumen is appearing intrinsically narrowed by opposition of the bony walls of the septum against the medial maxillary wall in absence of barren structure over obstructing masses, and it is located here in the middle of the nasal cavity, which is called mid-cavity stenosis. And it can be secondary to obstructing cause like maxillary sinus mucoceles, like here in case of cystic fibrosis. Other rare causes like nasopharyngeal atresia, a very rare malformation which is clinically indistinguishable from the more common posterior choanal atresia or pyriform sinus or pyriform sinus stenosis. Here the soft palate is not developed and the vomer is stuck or fused to the skull base, so we don't have any developed nasal cavity or nasopharynx. So these images here, the vomer is fused to the skull base, and here we don't have any developed nasal cavity. We have here oral cavity, but there is no nasal cavity at all because the hard palate is fused to the skull base, and we don't have any nasopharynx even. And a more rare form is persistence of buccopharyngeal membrane, and these are case reports. Only 30 reports are yet reported up to now. Here is a buccopharyngeal membrane. Here is separating the oral contrast, separating the oral cavity completely from the nasopharynx. But the difference here, we are having oral nasal cavity hypoplastic, and we are having nasopharynx, but this nasopharynx is not communicating with the oral cavity, and this is a very, very extremely rare entity. In neonates with airway obstruction, epiphora, and anterior nasal mass, the best imaging modality examination is also the CT. We are having here bilateral dacryocystoceal, which means cystic dilatation of nasolacrimal apparatus due to canalization defect congenital, leading to distal obstruction, and usually more in preterm newborn, trisomy 21, or branchioautorenal syndrome. It can be present with respiratory distress, epiphora, medial canthal mass, endonasal cyst, dacryocystitis, which can be recurrent. The cyst can be presenting as medial canthal cyst, or just a smoothly enlarged nasolacrimal duct but retaining the ductal appearance, or it can be presenting as endonasal cyst isolated, which can be difficult in diagnosis. Here, this is presenting as medial canthal cyst and endonasal cyst. A patient with or neonate, hyperthalamic, blind newborn with respiratory distress. Best imaging modality in this case, when we find hyperthyroidism, will be MR, because we are expecting midline brain anomalies, especially this cephalocele or meningocele, basal. So we have in basal cephaloceles herniation of the brain and meninges due to defect in anterior or middle cranial fossa. Incidence is rare, 1 to every 10,000 newborn. More common in Asia, Africa, Australia, Latin America. Associations with medial facial cleft syndrome and NF1. Here is basal, the classification, maybe transsphenoidal, sphenoorbital, transethmoidal, and sphenomaxillary. Other obstructing causes, the nasoethmoidal cephalocele, this is listed under the sensibital, not the basal. Nasal gliomas, rare masses like lipoblastoma, hairy teratoid polyp, and nasal septal hematoma. This is a nasoethmoidal cephalocele between the nasal process here of the frontal bone and the ethmoidal cribriform plate. Also, the nasal glioma means a dysplastic glial tissue, intranasal in 30% of overall gliomas. Intracranial connection is found in 50%, and in these cases the diagnosis is easy, maybe or may not associated with CSF leak. The nasal glioma is, can be readily diagnosed because it's presenting in the neonatal age, which means it has developed in the neonatal period. It has a signal and enhancement signal pattern like the brain and the gyriform appearance, and it is not enhanced and maybe surrounding by enhancing mucosal of the nasal cavity. The rare causes are actually the masses. Here's lipoblastoma with a typical fatty appearance, hairy teratoid polyp, which can be diagnosed only by biopsy. A 3-week-old with nasal congestion, here a non-characterizable septal mass. And by MRI, we can find only near a signal of a fluid and surrounded by mucosa with no enhancement of the internal septal fluid, here, internal septal fluid. And this was proved as nasal septal hematoma. This was more suggested by skeletal survey, which is revealing non-accidental trauma by appearance of calluses of the posterior ribs and healed fracture lines, because in pediatric age we're not looking for bleeding diathesis in this neonatal period, so we can think about trauma or the usual trauma or the non-accidental trauma. So to summarize, this obstruction of the newborn and the classification without MS, we have choanal atresia, pyriform aperture stenosis, and middle nasal cavity obstruction, and these are the most common causes, and we have to select CT as the best imaging modality. If associated with a mass, can be dacrocystocele, intranasal glioma, basal cephalocele, and these are usually presenting with hyperthyroidism, and we have to, the better is to resort to the choice of MRI in imaging of these patients. I have to acknowledge Dr. Gary Hedlund, professor of PCMC, a Primary Children's Medical Center in Salt Lake City, Utah, because he provided me with most of these materials of this lecture. And finally, I need to thank you. Thank you so much.
Thank you, Dr. Lamiaa. Now we came for the